When you meet with your patients to talk about all the different fertility tools we have to offer, there's a lot of different options. There's a lot of different initials we throw around: IUI, INVICEL, IVF. If we start with IUI, what do you tell your patients about IUI?
Sure. I start out. Yeah, IUI is an acronym for Intrauterine Insemination, and it's for a selected group of patients. Sperm have to get through two barriers to get into the upper reproductive tract. 90% of the sperm never get out of the vagina. Another 90% of sperm don't get out of the cervix. So it's one way of correcting low sperm numbers and enhancing that. It's also a way of improving morphology because of the washing technique that's done. The technique involves putting the sperm through a gradient and separating the liquid portion of the sperm from the cells. The liquid, that if we put one drop of that up in the uterus, the woman would have severe reactions, fever, cramping. So it's important to separate those two things, but also then can put the sperm directly up into the uterus. So once the sperm's been processed, we load it into a catheter, and there's a speculum in the vagina which exposes the cervix. And you can thread the IUI catheter into the intercervical os, through the cervical canal, up into the upper cavity, and then when you deposit the sperm in the upper uterus, you've essentially increased the sperm count by a factor of about 50-fold.
So you've washed the sperm so that the ejaculate is no longer there, and you've bypassed one barrier that may be making it hard for sperm to get closer to that woman's eggs.
So Susanna, how do you help your patients decide if they're a good candidate for IUI?
Well, for IUI to work, you have to have a sperm sample that's high enough that it can get through the washing process and still have a good number of sperm to put up into the uterus, and open fallopian tubes, because the only barrier that is going to be bypassed with an IUI is the cervical mucus barrier. The sperm still has to be able to swim up into the fallopian tube. The egg still has to be grabbed by the fallopian tube. They have to meet there and then make their way back into the uterus. So when patients have completed their fertility workup and they have a reasonable semen analysis, everything from normal to just a little bit abnormal, they have open tubes, they have eggs available. I talk to them about the data that shows that 1 in 4 couples will get pregnant in up to 3 inseminations. And if they are pregnant in those 3 inseminations, we've gotten to our goal. And if they're not pregnant in those 3 inseminations, we know that we must have another barrier. Either the eggs and sperm aren't finding each other, the eggs and sperm aren't interacting appropriately to achieve a fertilized embryo, or the fertilized embryo is not of the quality that is able to get to the uterus to make an implantation, to make an ongoing pregnancy. And so we would talk about other tools that we could use, such as INVICEL or IVF.